At the outset, I would like to thank AIOS for giving us the state of Uttar Pradesh a chance to present their speakers on this forum of APAO. And do we have Abhijat is not here yet? Demanat sir, Abhishek Chandra sir, Parul ma'am is here. So, Parul, can we start? If you're okay with that? Or if any of the speakers want to start, Amit boss, you want to start? So I would request Dr. Amit Garg to please present on his topic, toric IOL current trends. Dr. Amit Garg is a prolific surgeon practicing at Meerut, and he was the secretary of the last UPSOS annual conference, which was a wonderful one. We all enjoyed the hospitality of Meerut. It was really nice. So boss, all over to you.
Thank you, Ravindu. Thank you very much.
The President-elect of UP State Ophthalmic Society. I welcome our President, Dr. Malay Chaturvedi sir, to please come on stage.
बॉस का आशीर्वाद मिला बिना शुरू हो नहीं सकता था.
सर गुस्ताखी कर ली हम लोगों ने सबको वेलकम कर लिया आपके आने से पहले. So Abhijat, be ready as the second speaker.
Yeah. Good afternoon, everyone. Thank you, APO and UP Ophthalmic Society for giving me this opportunity. I will be discussing about the recent trends in toric IOL. Cataract surgery has now become a refractive surgery. Patient expectations, as you all know, are increasing day by day, and they want minimal dependence on glasses. Uncorrected vision gives rise to poor quality of vision, image distortion, and more than 1/3 of the patient have more than one diopter of astigmatism. The sources of astigmatism are anterior surface of the cornea, posterior surface of the cornea, and the lenticular astigmatism. Doctors are still hesitating in putting toric IOL because they feel that come at an extra cost, and secondly, the phobia of rotational stability. But the rotational stability is not an issue anymore. The IOL quality is very good. Technis has a frosted design, Alcon has a sticky surface, and obviously Indian lenses are also very good. Toric IOL need no extra skill. This should be considered in patients with astigmatism. Regular astigmatism can be easily corrected with toric IOL. It is better to avoid in irregular astigmatism. Recently, we also start considering posterior corneal astigmatism in measurements, and PCA is included in many recent biometer as a total K or TK. Importance of accurate biometry definitely is must to rule out any prior eye drop, any touch procedure, any surface abnormality. What should be the ideal thing to measure keratometry and the axial length? Obviously, the ideal thing is pentacam, and axial length is optical biometer. But in my view, if you don't have access to these equipments, you can very well do toric IOLs, because manual K and immersion gives equally good results. Before start, Dr. N.K. Singh sir, please. आपके बिना कैसे होगा? Before starting toric IOL, one must know his SIA. Many online calculators are available. Alcon Barrett, which gives printout like these. As we see the 3° almost adjacent to the incision, so we can mark at 3°, and definitely incision will be almost around that. Hoya calculator, you can give your data to any company. They will provide a sheet, Care Group and ASCRS Barrett toric calculator. Pre-operative marking is the most important step. One can do it on slit lamp or a bubble marker. I prefer to do it on slit lamp, and I don't mark 90° or 180. I directly mark the axis of the IOL, so that intra-op marking is not necessary anymore. If you have Varion and other Galsto devices, then there is no need to mark, obviously. Always make sure marking is when the corneal surface is dry, and don't use too much ink. A gross alignment is must. You must have to keep a printout of the sheet of the toric IOL in the OT. OVD removal under the IOL is must, and it is not a very difficult step. But the only thing you have to take in care of is when you remove the OVD behind the IOL, try not to dislodge the IOL up and down and right and forth. Don't rotate counterclockwise. Try to keep IOL at least 20 degree around before that toric mark during OVD removal. Then you align it with the mark and then hydro procedure. Post-operatively, if the vision is 6 by 6 or 6/9, there is no need to check or tell patient. But if you feel that the vision is like 6/12, 6/18, then you must dilate, check the alignment, because rotation on day 1, 2, 3 is easier than it could be later on. How much to rotate and how to rotate? We have a site called astigmatisfix.com. We can put that data and that will solve the purpose. If you are using for a premium lenses like trifocal and EDOF, then your threshold for toric lens uses should be low. I think it should not be more than 0.5. What are the tips for successful outcome? Basically, biometry accuracy is good. Single technician or maximum 2, which is well versed. Discontinue any contact lens, obviously any ocular pathology, dry eye, etc. Good pupillary dilation is a must. Incision on the planned axis, CCC is very important. If you have a small CCC, then the chances of rotation of the IOL is very less. And obviously, you have to remove the viscoelastic, or you can do a hydroimplantation. Loss of correction with rotation can happen. 1 degree rotation can loss of astigmatic power around 3.3%. With good pre-op assessment, accurate biometry and meticulous planning, optimum results can be very easy to achieve. Any surgeon who can do phaco can do toric IOL. Thank you very much. Any questions? No, why? Sir, if you do hydro properly, the pressure is so high. I mean, you can't tilt the lens easily till you go inside. I don't think there is any role of that. Any opinion, Navindu, Dr. Anil, sir?
Not required.
Not required.
Not required. It doesn't make any difference.
Thank you. Thank you very much.
Thank you, boss. Thanks for a wonderful presentation. And the best part was you finished in time. The, the session is already late, so I would request all my speakers to please be in time. Next in line, we have our young ophthalmologist, Dr. Abhichar Chaturvedi, who is a VR surgeon trained under Dr. Luthra, and he'll be speaking on OCTA for you all.
So very good afternoon to everyone, and I thank UPSOS at the outset to give me this opportunity to speak on OCTA. Why do I always prefer to speak on OCTA? Because I feel that this is the underdog of the retinal investigations. It's a beautiful investigative modality, just that we don't understand why to use it and when to use it. So I'll be just going about through some diseases. So this is a diabetic retinopathy slide, and what we can see, the red arrows, these show microaneurysms. So this is a patient which when seen clinically we couldn't see any signs of diabetic retinopathy. But as soon as you do an OCTA, you can see that these are CNP areas, these are some microaneurysms present. So clearly this patient has mild NPDR, and now our treatment course would change. Then very beautifully you can document the NVDs and NVEs. You do not need to inject any sort of dye to do that. This is a non-invasive modality. So similarly, in this image, if you focus on the superficial and deep scans, which I'll zoom now, you can see how beautifully neovascularization elsewhere has been documented. How do you identify that this is a new vessel? You just observe the caliber of the vessel. It becomes slightly broader, wider. You can see CNP around that. And moreover, the fluorescence also increases. So the purpose of putting these two images are that if you do an FFA, you'll always study just the superficial layer. You won't know what is happening in the deeper layer, in the outer layer, even in the choriocapillaries. And with an OCTA, you can study the pathology going in all the layers. This will help you in treating the patient, which I'll explain in the coming slides. So this slide shows that normally also in choroid there are flow voids. But what happens in diabetics? These all coalesce and become slightly larger. So coming on to vein occlusion, this was a patient of mine who presented with vein occlusion. So when I did an octa of this woman, so this is the image of a superficial layer, which you will also see on the FFA. But now notice that as you are going deeper and outer, the amount of non-perfusion increases. So this shows that this patient has an ischemic insult, not a non-ischemic insult. You can also quantify this, that what is the vessel density there, how much is the amount of perfusion present, which can be done in all the layers. Now, why do you need to do this sort of quantification? This is for the treatment purpose only. So this was what was before injection. After injection, the entire image changed. Now I'll come to the importance of quantification. So on the left is pre-injection, on the right is post-injection. So if you notice the central part, it had a vessel density of 36, which increased to 44. Similarly, in the entire, all images, all the layers, these values are increasing. So you can counsel the patient also, there is some reperfusion which is happening, which you cannot do with an FFA or an OCT. And again, this is a non-invasive modality. So this was a rare case of a triple cilio-retinal artery sparing CRO. You can see that the entire macula is non-perfused. After the treatment of the patient's cardiac illness, you can see that how beautifully the entire retina is now reperfused. Similarly, this is a case of old STBRVO. Had I not done this octa, I wouldn't have gone for an injection because the OCT doesn't show any sort of macular edema. But on octa, you can clearly notice the new vessels developing. So just because of this, I will go for an injection of this patient. In dry AMD per se, there's not much role of octa, but yes, in wet AMD. So this case shows clearly that there are huge geographic atrophy scars. But if you notice the superficial and deep layer, which I'll zoom now, so there's something going on over here. A polyp-like structure is developing, which is encroaching the foveal avascular zone. And just for this, I'm going to go for an injection. And octa is very useful in differentiating type 1 from type 2. So this is a type 1 CNV, where you can see that superficial area is fine. However, CNV net develops in the deeper, in the outer, and the choriocapillaries. Whereas in this image, this CNV net and non-perfusion develops from the superficial to the deeper, to the outer. This is not a CNP area. Rather, this is just a masking effect because of the fluid present intraretinally. There are huge types of, various types of CNV nets, which you need to know. This has some prognostic value as well attached with it. So this is my final case, and this is a young girl having choroidal osteoma with CNV. This is again a published case. So this CNV net can be documented beautifully with an octa. And this girl was injected. After 6 weeks, some regression was noted, but not a lot. The girl was re-injected again. And now you can see that in the outer layer, how beautifully the net is regressing. So this regression of CNV net documentation is also important because many a times with injections, these nets regress and you actually treat this. You cannot document this with FFA or an OCT. So my take-home message is that it is a non-invasive modality. It shows beautifully the retinal and choroidal architecture. It is very helpful in detecting a preclinical disease, which no other modality offers till now. It is a very good patient education tool, and it helps in monitoring the disease progression and observe the prognostic value of the condition. Thank you for your patient listening.
Very nice. I think one question. One advantage of octa over OCT or angiography.
So yes, I always say, octa cannot replace FFA. Both the modalities are at their own places. But yes, octa has an advantage of being non-invasive. So if a patient of hypertension or a kidney disease comes to you, you do not need to inject any dye. You just straight away go for an octa and you'll get the, the entire image, and your treatment can go ahead. However, FFA carries a huge risk of having a reaction, anaphylactic reaction maybe.
Give the floating mic, yeah.
They are both complementary.
I totally agree, sir. FFA cannot replace Octa. Yeah. Should change. Yes, it becomes mild NPDR. Yes, yes, yes. Definitely, sir. Agreed. Agreed, sir. Thank you. Thank you very much.
Wonderful. So after Abhijat, Dr. Dhaminath sir has not reported now. Abhishek Chandra Bose is not here. Parul ma'am, can we go ahead? Yeah. Dr. Parul Singh, she's a professor at GSV Medical College, and she'll be speaking on aesthetics in oculoplasty. And this is what I had, I mean, in her introduction I had said that she's aesthetically so beautiful. So similarly, she'll tell us what are the...
You give all the time.
Yeah.
Last time also remember the seminar.
This is
Thank-
what
Thank you so much.
this is how I introduced her in Sri Lanka also, and everybody was gaga.
Thank
So
you.
over to you, ma'am.
Thank you, Naveen. So, good afternoon, everybody. I would be speaking on aesthetics and oculoplasty. Now, why aesthetics and what is the need to introduce aesthetics in oculoplasty? So, aesthetics basically means something which is visually pleasant. So basically, aesthetic and cosmetic eye procedures are a group of those procedures that improve the appearance of the eye as well as the face. Now, but most of these surgeries are not performed on the eyes, but they are performed on the surrounding tissues rather than on the eyes. So the scope of aesthetics in oculoplasty is basically first in reconstitution of orbital structures, second in correction of eyelid deformities, and third in enhancement of eye appearance. Now, there is huge importance of aesthetics in oculoplasty and otherwise also in our daily lives. The foremost is that it enhances the self-esteem of the patient. It enhances the overall facial aesthetics and definitely enhances and boosts the confidence of the patient in the social settings. Now, to simplify the classification, I have classified the aesthetic procedures into two. First is non-surgical and second is surgical. So to briefly enumerate non-surgical ones, most importantly, which we are doing most commonly is the botulinum toxin injection. Second are the fillers. And third are the rejuvenation procedures. Most of them are done by the derma friends. Surgical procedures I would like to simplify and classify as blepharoplasty, ptosis, and browplasty. Now to talk a little about botulinum, it has come a long way from being used as a war toxin to now used as a therapeutic procedure. Basically, in simple words, it basically inhibit the release of acetylcholine at the muscle, so it causes a muscle paralysis. So acetylcholine is inhibited at neuromuscular junction, which causes the paralysis of the muscles. It's a light chain and heavy chain, so not going into the detail of the molecular structure. Commercially, botulinum is available as a type A or type B. Commercial names are there, and type A is more popular because it's stable, purified, and has a longer duration of action. It has to be reconstituted with sterile, non-preserved one, and it should be definitely stored in refrigerator at 4 degrees Celsius, and after reconstitution, although the label says it has to be used in 24 hours, but we can comfortably use it for 6 weeks. Now for different clinical conditions, as I have listed, the dosage would be different. Now, indications would be, most importantly, botulinum is used in facial dystonias, for example, hemifacial spasm, BEB, ocular myokemias. They can be used in senile entropion, tarsorrhaphy, and for cosmetic indications used very widely these days for dynamic facial wrinkles and chemical brow lift. So now this is a patient of abnormal twitching, you can see. In this patient, you can see this is a patient of hemifacial spasm, and you can see closely, and here it becomes very difficult of these lives of these people. So here we are marking it, and you can here see that the twitching has gone, and here the patient is fine. This is a patient of benign essential blepharospasm before injection, and so the life of such patients is really difficult. And you can see here, before injection, this is a patient after the Botox injection. So injection of botulinum toxin results in varied degrees of muscle weakness depending upon the concentration and the dose we have used. Effects are basically noticeable within 1 to 2 weeks. They peak at 2 to 3 weeks, and actually they begin to subside at 4 to 6 months after administration. So that is to be told to the patient beforehand. Now, these are the patients in which we can use in the facial wrinkles. They are the pictures of crow feet before and after. Here we have glabular furrows before and after picture. This is a picture of wrinkles before and after the use of botulinum, and these are a picture of the forehead lines. So the contraindication will remain motor neuropathic disease, any neuromuscular junction disorder, pregnancies that has to be avoided, any cases of infection, and hypersensitivity, they need to be avoided. Complication can happen if we do not take in regard the dose, and if we go in the wrong planes or we overuse it. It can lead to ptosis, leg of thalmos, entropion, ectopion, epiphora, diplopia, etc. Now coming to dermal fillers, the dermal fillers can again be of reversible, semi-permanent and permanent, and out of those, hyaluronic fillers are more popular because they are more natural occurring, they are biodegradable, dissolvable, reversible, have a good safety profile. They would be indicated in facial lines, post-surgical traumatic scars, dark circles, and most commonly these days in tear trough hollows. And I'll show you the example here. This is a preoperative patient of these tear troughs as we see as the hollows, and after use of the fillers, the cosmetic appearance has improved a great deal. The contraindication would be if it is positive to skin testing, autoimmune disease, and anaphylaxis, and of course patients of unrealistic expectations have to be excluded. Complications can be allergic or vascular, or it can lead to abscess very rarely. So the pros of fillers are that they are give very instant results, easy technique, simple OPD procedure, but they can be short lasting, costly, and can cause some adverse reactions. Coming to the surgical ones in short, so the most commonly one is blepharoplasty, which would be most commonly indicated in dermatocalcinosis and staphylonephron. Here you can see this is a patient of this blepharocalcinosis, pre-op picture and post-op picture. This is a patient of staphylonephron. You can see this lower fat, which we can see becomes very cosmetic unpleasant, and you can see the picture has improved a great deal after the blepharoplasty. Upper lip blepharoplasty in short, I would say we would mark first, we do pinch test here. We remove the skin along with the underlying muscle in one layer, and then we close it with 6-0 silk. Similarly, lower lid blepharoplasty, there can be two approaches, transconjunctival and from skin side, we prefer transconjunctival approach. We apply traction suture, we give incision, expose the fat. In the lower lid, we have to be very careful about the inferior oblique because we have to remove central fat, nasal fat, and lateral fat as well. And then we reposit the conjunctiva, and it looks like this. Now coming to ptosis, as we know, ptosis is basically can be divided into mild, moderate, and severe. So we have to see for the risk of amblyopia, and cosmetic concern is definitely, this is a patient in which we do facial Savard procedure in a mild ptosis, left upper eyelid, pre-op picture and post-op picture. Here we are doing levator resection in 20-year-old boy with moderate ptosis in left eye with good levator function, and post-operatively it looks like this. Similarly, frontalis suspension is done in a patient of severe ptosis with poor levator, and it improves to a great deal. And this is a ptosis repair done for aponeurotic ptosis in a 63-year-old female, bilateral. And so this is it. Thank you so much.
I think it's please stay on. Yeah. You have given such a fantastic presentation, and I think we need some comments on that.
Sure, sir.
Because we still have time.
Okay.
We'll make use of that. As far as this fillers are concerned, what do you think, how practical it is in our scenario, and what is the availability?
So availability is not an issue. Actually, the use is basically for cosmetic purposes. So it depends how much cosmetic aware we are and how much are we working in that part of the socio-economic status of the people. So only people from higher socio-economic status have that much of time and money actually to invest in looking more pleasant as they are. So that way, but I would say the use of botulinum has made a great difference in lives of people, especially these patients of blepharospasms and hemifacial spasms. The life changes actually, although repeated injections, it remains an economic burden to them. So, but I think blepharospasm, they have done a great deal in the lives of the people.
A word about availability.
Availability is not a problem at all, sir. Availability is not a problem. So fillers last for, so cost would be higher for fillers. It would be something around 30,000 to 50,000, and they would last maybe for 1 year to 1.5 fillers. Toxin, botulinum toxin lasts a little shorter period, like 4 to 6 months sometimes, but that's how it is. Until we have some long-lasting treatments, we have to depend on these.
Yeah, thank you very
Thank you,
much.
Thank you, ma'am. And next we have with us Dr. Abdul Waris Bose. Dr. Abdul Wais is professor at AMU University at Aligarh, and sir will be speaking on the basic science and micro level intervention, which is the future role in diabetic retinopathy management.
गुड आफ्टरनून इट्स अ वेरी होमली एटमॉस्फेयर और अपने यूपी के लोग हैं तो आई एम मोर कंफर्टेबल तो आई विल बी टॉकिंग अबाउट द न्यू menace we are facing, that's diabetic retinopathy, and as we all know that it is going to touch about 100 million very soon, and we have a huge shortage, I don't know, we have a huge shortage of retina specialists, especially in the periphery, especially where the rural population has a very poor compliance. We have got an array of recent advances in diagnosis, in management. We have all sorts of anti-VEGFs, all sorts of advances in anti-VEGF. But what is the need of the hour? The need is that we should focus on low-cost modifying factors, which has not been explored yet, especially in the Indian scenario. Okay. One very interesting thing was that came recently was the gene therapy and genetic research. So I will just share my researches and what I am planning to do in the next few years, and what we should think about how to manage it in a more economic way with the facility in our country. Okay. This was one of the theses where we found that in diabetic retinopathy there was two types of polymorphism, namely -374 TA and -429 TC. These were the procedure how we basically located these polymorphisms. Okay. In the near future, if we have got a CRISPR technology and we can just cut that area of polymorphism, probably diabetic patients won't develop diabetic retinopathy. Okay. Another work which I did was on brain-derived neurotrophic factor. In diabetic retinopathy, basically we are focusing on the vascular aspect. We are not focusing on the neurological aspect. It's a neuropathy also. Okay. And we found that there is a huge shortage of BDNF in advanced diabetic retinopathy cases. That means if we treat the patient with with BDNF therapeutically, probably diabetic retinopathy is going to improve clinically. These were the statistical figures which collaborates that there is a low rate of BDNF in diabetic retinopathy advances as the stages advances. Other researches, I saw that this human retinal binding protein, which was a very good blood-based biomarker to test diabetic retinopathy. Okay. Some of the hormones, estrogen these are all my personal researches with my postgraduates. We saw that estrogen had a protective effect on diabetic retinopathy. That's why females up to 45 and 50 like that, they are protected by and then after that they develop it very fast actually. So it has got a protective effect. We can think of estrogen as a therapeutic agent also in the research. On the contrary, progesterone and cortisone, they were having the opposite effect. Okay. We all know that diabetic retinopathy and hypothyroidism both are autoimmune diseases, and they both go together. Okay. So I always tell my students and my patients, any patient of diabetes and diabetic retinopathy, get your thyroid level also checked. Okay. As I told, serum cortisol was very high with higher stages of diabetic retinopathy. Same was the case with bone turnover markers. That means huge amount of hypocalcemia was there in advanced stages of diabetic retinopathy. Okay. These are some of the other studies I am going through, that is on epigenetics. And we found that one of the steps, that is DNA methylation, can be taken control of in managing diabetic retinopathy. I'm not going through the details. Some of the inflammatory marker very conclusive for retinopathy, that was TGF-1 and ICAM, is going on. We all know the role of deep learning, AI, and telemedicine, nanotechnology, stem cell therapy. What I want to stress on this talk was on two things. One, recently we have found that it is the mitochondrial dysfunction, which is one of the main factor responsible for diabetic retinopathy. And along with antioxidant therapy, people are trying to find some mitochondria targeting antioxidants like MitoQ and like that. Okay. And there is a impact of microglia on the vascular units. They are thought to aggravate diabetic retinopathy. Okay. Very interesting thing I wanted to highlight again was the role of gut retina axis. In India, we have got a very healthy food habits. We don't take junk foods, which goes with our Indian tradition. We take a lot of dahi and all. So it was now it is being basically postulated that if your gut is healthy, your retina will be healthy. I'm going to give the next thesis on this topic. Okay. These are the role of prebiotics and probiotics and how dietary intervention can improve our gut and eventually our retina. Lastly, the behavioral factor, a stress-free life, mindfulness. Yoga has a big role, but we have to find some evidence-based medicine to see the role of yoga and the different asanas on diabetes and diabetic retinopathy. Again, my another interest which of mine is the role of the connection of diabetic retinopathy with Alzheimer, because both are neuropathies, and literature have shown that with the advancement of diabetic retinopathy, people are having dementia, they are going through Alzheimer diseases. So once I did my thesis on BDNF, probably next I will try to correlate diabetic retinopathy and Alzheimer. Just imagine a patient who cannot see and cannot think or uses his memory. So this will be my future study. At the end, I would like to just stress upon that we have cutting edge technology, but I think we should utilize this cutting edge technology and amalgamate it with our Indian tradition and change in behavioral lifestyle. Thank you so much.
Very nice, Dr. Waris. One quick comment from Dr. Sandeep, who is sitting here, retina expert. Can you give the mic, please?
Yeah. जुड़ के आ जाए ऐसे. Because I have done about 12 to 14 topics on diabetic retinopathy itself. If I can just bring it together, sir. And I will take your help to her. You can suggest us, sir, कैसे करें इसको.
उसको लिंकिंग अगर हो जाएगी तो बहुत अच्छा उसमें रहेगा.
Yesterday we did an IC on inflammation and neovascularization, and a lot of discussion was on diabetic retinopathy, and you were also talking something which is nearer to what we were talking. So I think there is a need to interact with each other within the state. Yeah, Dr. Parul.
Sir, when you say the gut health, it helps in controlling diabetic retinopathy.
No, there are good bacteria which like
So
that.
it would
That
be-
has got a retinal axis. There are literature, but I haven't worked on it.
Okay.
Probably I will just
both.
do both.
Maybe with-
with diabetic retinopathy and patient who are having probably chronic some elementary disease or
So
something.
is that
like
general inflammation which if the gut is not healthy and if we give prebiotics, the gut becomes healthy. So does it reduce the general inflammation, which reduces the inflammation of the retina?
I'm not exactly clear how the
Okay.
gut is
It
related to
works.
retina,
We have to
but
find out.
literature are supporting it.
Okay.
Probably sir could add something, I don't know. Something. But I just remember,
नहीं,
मतलब,
for
just for
long-
the sake of discussion, पुराने जो हमारे वैद्य और हकीम कहते थे कि अगर आपका पेट साफ है तो 100 बीमारियां से आप बचते हैं. There must have been some relation. Maybe sir will add something.
I think there has been a relation and ये जो आपके वैद्य लोग पहले त्रिफला तो हम लोग उतना यूज़ नहीं करते, बट वो तो आयुर्वेदिक का एक मेन फैक्टर है, and that is mainly focused on the gut health. So if we keep our gut well, things will be well. And the January issue of IGO retina वाला जो issue है, so that has an article on this
Gut retina
gut
axis.
and the retina
Maybe
axis.
something to do with immunology or vascularity.
Yes, तो वहाँ से कुछ
वहाँ से
आपको
कुछ मिलेगा.
और input
But I
मिल
will work
सकता
on
है.
it, definitely. Thank you, sir.
So I think the next speaker, Dr. Nahid.
I would request Dr. Nahid Akhtar ma'am. She's professor at AMU Aligarh, and she's wife of our very own Dr. Waris Boss. She'll be speaking on VEP, the next mandatory tool in management of amblyopia. So Abhishek Boss, please be ready after this, because Kapil sir is ready. Kapil sir was here, just left.
Is it working? Very good afternoon to all the esteemed audience here. नहीं है शायद. A very good afternoon to all the esteemed audience here, people on the dais and off the dais. I will be talking about VEP, the next mandatory tool in the amblyopia management. So we did one study in our institute, and that is, I'm talking about that. Amblyopia, as we know, is the leading cause of visual impairment in children with a global prevalence of 1 to 6%. Can be classified into strabismic, anisometropic, and stimulus deprivation amblyopia. Visual evoked potential, it offers as a non-invasive method for assessing functional integrity of the visual pathways, making them crucial for diagnosing amblyopia. The P100 component of VP in particular is often delayed in amblyopic eyes, reflecting disruption in visual processing pathways. Vitamin B12 is essential for normal functioning of nervous system. However, deficiencies potentially lead to various neurological disorders, including optic neuropathy. So the aim of this study was to explore association between VEP and B12 levels in different types and grades of amblyopia in North India. Understanding this relationship could enhance the diagnostic and therapeutic strategies of amblyopia management. So it was a prospective cross-sectional study conducted at Institute of Ophthalmology, JNMC, from September 22 to 24. And the criteria we took was that from 6 to 16 years of old children, and around 45 children were taken, who had unilateral amblyopia and either strabismic or anisometropic. So this was the exclusion criteria, and the methodology we use VP to record our in these children and as routine, and V12 levels were estimated by CLIA method, and blood samples were collected and processed, and all this statistical analysis was done. And coming directly to the results, we had 28 males and 17 females. And out of that, 24 were having anisometropic amblyopia and 21 were having strabismic amblyopia. The severity of amblyopia was classified as mild, moderate, and severe. And VP latency was found to be significantly longer in amblyopic eyes as compared to the fellow eyes, with mean latency as 128 and 108 respectively. So, and the amplitude was also found to be significantly lower in amblyopic eyes as compared to the fellow eyes. However, no significant difference was observed in VP values between strabismic and anisometropic amblyopia across different grades of severity. So this is the chart showing the differences in mild, moderate, and severe. And the values were, the latency was increased in all grades. And here it was the amplitude, which showed also there was a decrease in the amplitude. And however, the B12 level in the study population was 123, with no significant difference observed between strabismic and anisometropic amblyopia. Now coming to discussion, this study bridged the gap in understanding the relationship between VEP and B12 levels in different types and grades of amblyopia. And our findings were going with the M. Gitanjali's study, in which increased VEP latency and decreased amplitude was found before treatment, and which improved after occlusion therapy. So they found that VEP changes will reflect improvements in visual processing capabilities of brain as a response to treatment. Also, this Shaukat et al., they found that significant difference between amblyopic and fellow eyes with respect to VP pattern onset components. The reversal also showed significant differences, and these findings concurred with our study. Kumar also found that P100 values significantly improved during occlusion therapy in patients with strabismic, and improvement correlated positively with Snellen's chart. Haefeld also explored 65 amblyopic children with pattern reversal VEP elicited by checkerboard, and they found that all the three types of amblyopia, they showed improvement. These findings did, however, these findings did not align with the present study where we found significant difference in P100 latency and amplitude between amblyopic and fellow eyes of the same subject. The difference could be due to combination of factors including differences in study population, methodology, and interpretation of clinical and neurological data. When comparing P100 latency across different grades of amblyopia, the present study found no significant difference in different grades of amblyopia. In the present study, B12 levels did not show significant difference between strabismic and anisometropic amblyopia when analyzing B12 levels by the severity of amblyopia. A similar study by Subashi et al., they evaluated amblyopic children and they found lower levels of B12 and folate levels and higher body mass index in children. These findings, they are same as our study population, and they exhibit our study population also showed deficient B12 levels in amblyopic patients. The limitation of our study is that we have a small sample size and cross-sectional design. It limits its use. Future research should include larger longitudinal study to better understand the role of VEP and B12 in amblyopia. So VEP showed, then coming to the conclusion, VEP showed significantly prolonged P100 latency and reduced amplitude in amblyopic eyes compared to the non-amblyopic patients. No significant difference in VEP parameters were found in anisometric and strabismic amblyopia. And VEP values did not vary significantly across different grades of amblyopia. B12 levels were generally low in study population. However, the differences were not significant. Thank you.
In this, what is the advantage of doing VP?
So actually, we know that amblyopia is something, if it is not taken into account at early stage, the things become irreversible. So at least we can set up a baseline, a parameter, just to monitor how it is going to pre-treatment and post-treatment. And it can be very convincing to the patient also.
More convincing will be the vision. The vision is 618 and they improve to 12 and 9. That will be more convincing.
Yeah, but just to monitor the this vision is of course the most important parameter. But when we do this VP analysis, we can have a baseline and we can just have an objective estimation ki we have this finding. So,
thank you.
Patient subjective. Because actually nowadays we are living in an era where we have to prove ourselves every now and then. Every now and then we have to prove because OCT hai, ye, wo hai, hum to patient ko dikhayenge nahi, patient is not getting convinced. So we need to, even if we know that this optic nerve is not having, this patient is maybe PL negative, he will not understand. We are not showing.
In my practice, what I have observed, that if VP values are at borderline and vision loss is huge, even VP parameters are borderline, not very much delayed, not amplitude is not very low, then prognosis is good. They develop improvement very quickly. So that is the main importance of the doing BP. Otherwise, just for correlating, it is parallel, not a great advantage. Yeah. So whenever the VP is latency is not very bad, amplitude is not very bad, then we feel that with exercise, it is going to improve quickly.
Yeah, patient.
And it happens also.
Yes, sir.
Thank you.
I think it's a very good idea using VP as a prognostic factor.
Yes, sir.
I'm so happy that people are interacting with each other, giving UPSOS academics a different dimension. Yeah, Dr. Shalini.
So VP is sometimes very helpful to us when we are giving visual disability certificates, and the patients, they try to think that they are unable to see, and we are unable to find any corroborating findings. So there we get the VP done, and if it is absolutely normal, we don't give visual disability certificates to them. So that way also it is very, very helpful to bail us out.
We'll have a bigger section in our UPSOS meeting, and I'm really happy. Yeah.
Thank you.
Tahir ma'am.
Thank you.
And next in line, I would like to request and invite our president, Dr. Malal Chaturvedi sir. He will be speaking on Chaturvedi's chopstick technique.
So I would like to work like a spinner who will take over the lost time by the fast bowlers. Uh, so this study is now published, courtesy Dr. Abhijat's writing skill. I have been talking about this for quite some time, and Dr. Anil knows about it. These are the two things we published were, one was the code to crack nucleus, another thing was Chaturvedi chopstick grip. So whenever, today I was teaching to a phaco student, and I was telling her that actually before going in for phaco, you have to talk about incision planning and orientation. So I will skip these slides and I'll go on to this video. I hope it runs. Now suppose if this video doesn't run, 36 चैम्बर शाओलिन में वो जो मॉन्क था उसने एक खोला उसको, पहले वो स्ट्रेट से लड़ता था, फिर वो गया उसने कहा क्या करें इसको, तो उसने एक नॉन चॉक टाइप का बना दिया, बीच से उसको काट दिया, ये क्लिप उसको दिखा रही थी. So that changed the entire picture of the fight. Just like if you just change your grip, your total attitude towards phacoemulsification will change. That is the basic point which I wanted to make in this. And again you see, I don't know whether these videos will run or not. Yeah.
Hi, today I am going to tell you about the Chaturvedi chopstick grip, and you will realize simple change of grip will make how much difference in your life. Normally we hold the phaco with a pen grip, so this is pen grip. If you hold it by pen grip, then the depth achieved is this. Now what I will do, I will change it to the chopstick grip. This is a pen grip, and I will now convert it to chopstick grip. By going chopstick, you can go deeper, and that's the beauty of this grip. Instead of a pen grip, you go chopstick. With this grip, you can go inside quite deep. You can go subincisionally, you can move around and rotate pretty well.
Yeah. So I think this video has told everything, and let me see if I can another video of a minute or so. So, abhi run nahi kar raha hai. So basically what is happening, this idea has been taken by retina surgery, where the thing is, when we can work 3.5 millimeter away from limbus and operate the whole eye, why can't do this on limbus? So instead of making a 3-port phaco, we started doing 2-port phaco. And the way Macammer has told us to handle the grip of this vitrectomy probe, I have started using the phaco probe like that. So anyway, I think if this video doesn't run, my job is done. The way Macammer is using, asking you to hold a vitrectomy probe, if you hold it, the phaco probe like this, you can make deeper maneuvers. And that is Chaturvedi chopstick grip. Thank you very much.
Thank you, Malay sir. I welcome Dr. Shanmugam sir. And next we have Abhishek boss. Can we? I would request our sandwich secretary of UPSOS, Dr. Abhishek Chandra, who will be speaking on adjustable sling for ptosis. The session is running late. We got a session late, so I would request the next session people to please bear us with for the time.
Till he is bringing the connector, can anybody else start the next program? Yeah, he has got it.
Shalini ma'am?
Yeah, Dr. Shalini, if you are ready, you can join. And we have one more presentation of Dr. Akanksha, Dr. Sakshi.
Dr. Sakshi, your presentation is ready, right? Okay.
Dr. Shalini.
After this, Dr. Sakshi.
Hmm?
After Dr. Shalini, Dr. Sakshi.
So thank you so much UPSOS, and thank you so much AIOS for having me here. I am going to talk about microinvasive glaucoma surgery, when and how. I don't have any financial interest. So according to the workshop of American Glaucoma Society and US FDA, MIGS was characterized by implantation of a surgical device or removal of tissue, especially trabecular meshwork, intended to lower intraocular pressure via an outflow mechanism with either an ab interno or ab externo approach associated with low or no scleral dissection. So why microinvasive glaucoma surgery? Because these are new bunch of options for all type of glaucoma with minimal tissue trauma. There are good and short postoperative visual recoveries there and can be combined with phacoemulsification. So it claims to revolutionize the glaucoma management because there is no conjunctival dissection and therefore no bleps, no wound modulation. IOP reduction is although lesser than trabeculectomy but at least 20%, and there is high risk of safety profile. So what are the indications of MIGS? It is mild to moderate primary open angle glaucoma, pigmentary glaucoma and pseudoexfoliative glaucomas. But then there are several contraindications like eyes with angle closure glaucoma, eyes with neovascularization, any hazy cornea or if there is anterior chamber and dysgenesis, and any patient with raised episcleral venous pressure like Sturge-Weber syndrome, and any type of advanced glaucomatous optic neuropathy. So when we classify this a microinvasive glaucoma surgery, there can be main 4 approaches of reducing intraocular pressure by MIGS. So first one is it increases the outflow across the trabecular meshwork through Schlemm's canal by bypassing the trabecular meshwork. It enhances the uveous scleral outflow by supragroidal space. It shunts the aqueous into the subconjunctival space and decreases the aqueous production by ciliary processes ablation. So these are variety of technique. So this is a classification of trabecular meshwork bypass which we are doing more commonly. So there can be placement of any stent like iStent inject, hydrus, or there can be tissue excision or tissue ablation like with Kahug dual blade, trabectome, GAT, ELT and ab interno canaloplasty. So I will be discussing more about Kahug dual blade and its other methods which we are doing at our center. So the Kahug dual blade goniotomy has been introduced by US in 2015, which is ab interno approach. Now here we can see this blade, which is a stainless steel disposable blade with dual blade having sharp tip, designed with taper or smooth entry through trabecular meshwork. If you see the heel of this particular blade here, it fits very easily in the Schlemm's canal for smooth advancement. And this is the ramp of the blade that actually has a dual cutting edge and creates a parallel cut into the trabecular meshwork. And therefore, there is complete removal of trabecular meshwork and very little amount of surrounding tissue damage and therefore less of fibrosis. So here we can see this parallel excision of trabecular meshwork. But important thing are several prerequisites like neck mobility should be good. There should not be any tremors. Patient should be cooperative and angle should be visible in the clinic in your pre-operative evaluation. So here we need to position the patient nicely. We need to sit temporally, and what we need to do, we need to turn the patient heads to opposite side, and we need to tilt the microscope towards ourselves, and so that we have this kind of configuration. So here we can see this tilting, where patient is tilting opposite, and the microscope has been tilted towards us at 30 degrees. So this is the direct gonioscopy being done. Here we can visualize the nasal part of the trabecular meshwork. This is the KBD knife. And here we can see this is a shaft which enters the anterior chamber after your phacoemulsification surgery. So this is the visualization of pigmented part of trabecular meshwork, and the heel rests nicely onto the surface of Schlemm's canal, and then we have to strip the trabecular meshwork. So once stripping is being done, we can see that small amount of bloods, they start oozing out. We take a forceps and then strip the trabecular meshwork, and therefore the aqueous starts draining directly into the Schlemm's canal. So the efficacy has been proven to a wonderful levels of around 20%. It has shown comparable results with other device, and these are the several of the studies. Now, because this Kahuk dual blade is slightly costlier device, and therefore this modification of bent ab-internal needle goniectomy has been done, commonly known as bang surgery, where we take this 26 gauge needle, we bend it just opposite to the capsulotomy, what we for our phacoemulsification. And again, similarly, we visualize with the help of direct gonioscope. Here you can see the trabecular meshwork nicely, and the scleral spur is also visible just beneath the trabecular meshwork. And here you can see stripping of the trabecular meshwork. Only thing is, because here the cut is slightly irregular, so chances of fibrosis is more often and more common in bang surgery. But because it is a very cheap the surgery to be done along with phacoemulsification, so nowadays people are doing it quite commonly. So these are our results. We found 20% reduction in our patients also, with a reduction in anti-glaucoma medications in our subset of patients, although we had some complications like hyphema, but then it resolved very nicely. So these are the literature review for bang surgery. So to summarize, I would say that these new category of procedures, they have acceptable safety profile and humble efficacy. They, although unlikely to replace the traditional glaucoma surgery of trabeculectomy, but then in mild to moderate glaucoma, to fill the void between the advanced glaucoma and these mild moderate glaucoma, it is a good amount of surgery, expanding the horizon of glaucoma surgeries. Thank you so much for your kind attention.
Very nice. Yeah.
Thank you, sir.
Thank you, ma'am. Thank you very much for this wonderful presentation.
Dr. Shanley, what is the percentage of hyphema in your cases?
What is the follow-up period? Do you think it's a primary procedure? It can be a primary procedure. Instead of going to trabeculectomy, you go for this one. We have to wait.
Yeah,
Over to
Doctor.
you, Chandra boss.
Yes.
Yeah, Dr. Abhishek.
So thank you everyone, especially the UPSOS Society and the AIOS Society for having given this opportunity. So I will be speaking on the long-term results of adjustable frontalis suspension surgery, sling surgery for various types of ptosis. I have did many times live demonstration in Gorakhpur annual conference, also at UPSOS and at Allahabad. And so I will be presenting the long-term results of my case, and I will be, because the time is short, I will just be showing an animated video. So surgical management of ptosis still remains a challenge, because at the time of surgery and the final results, there can be a lot of difference. And the reasons for not achieving a desired height is whenever you give a local anesthesia, there is some amount of edema which is there. In general anesthesia, you cannot correlate with the other eye. The patient is lying in the supine position, there is a lid swelling, and there is a lot of anxiety of the patient in the operation theater. So we are here by describing a special technique that is adjustable frontalis suspension technique by myself. And it's a retrospective design. So in our study, we operated a total of 182 cases, and out of them 160 who had a follow-up of minimum of 1 year were taken in this study. The study was performed at Netrodaya, Chandra Eye Care, and at BHU from 2007 to 2022. And almost all varieties of cases that are congenital ptosis, blepharophimosis syndrome, traumatic ptosis, third nerve palsy, myasthenia gravis, CPEO, Marcus gun, epineuritic, tumor resection, everyone was taken. So I'll just go on to the video. So how we do it. So this is an animated video. So we mark 2 incisions here at the lid crease, then 2 at the brow and 1 at the forehead. And then we pass a oro sling, which is from Oro Lab, from the top incision in a Fox pentagonal method. So we start from the top, go to the nasal brow, and then we come to the lid, and then we pass on to the other side, and then we again go to the brow, and then we come out from the main incision. So this is a normal Fox pentagon method. So what deviation we have made is, after we come it from here, there is a Wattke sleeve which is attached in that oro sling. So we pass the sling in the opposite direction. And then from the opposite direction, again we pass it sub beneath the muscle, and then we take out from the other sides. So you can see we have not tied it anywhere. We have just passed to the Wattke sleeve as Dr. Varis or all the retina surgeons have been doing with the retinal sling. And then we have taken it from the other side. Now what will happen on the, I will just go a little back. So, and we leave it like that. So we do not correct the ptosis on the first, on the table. And on the next post-operative day, when the patient is on the sitting position, we pull both the green, which is mentioned here as green. And when we'll pull both the green strings together, this lid will elevate, because this is in a form of an 8. So when we'll pull both the strings, this lid will elevate, and then we can have the exact desired size as compared to the other eye, or maybe slightly more on the next post-operative day. The other thing is, if there is a slight change in the contour, for example, let's suppose the temporal is slightly lower, the nasal is slightly higher, you just pull the nasal side. So when you will pull the nasal side, the temporal lifting would be there. So you can also manage difference of the contour via this technique. So I'll just conclude by the results. Which what we got was, because the time is short. So these are the pre-op and post-op photographs. You can see we have photographs of almost all the patients. And at the end of 1 year after surgery, desired lid height was achieved in 152 of 160 eyes. Till the completion of the study, 136 eyes achieved good elevation and did not require any further surgeries. Resurgery was required in 16 patients from 1 month to 10 years follow-up. So if there is a patient who comes 10 years after the surgery, you don't need to repeat the whole procedure. You just need to open the superior incision, take out the Wattke sleeve, just tighten it and put it up back again. So it's a very, very simple procedure, and the whole surgery need not be repeated. And 8 patients in this study had mild ptosis, but they did not give their consent for further surgery. So there were very few complications. The most common complication was undercorrection in 20 out of 160, and out of them we operated again on 12 patients. So the advantages are that the adjustment is done on the next day without the effect of LA or GA, without any lid swelling, in sitting position with both eyes open in consultant chamber with the patient attendant there itself. So they can also make a judgment that you want to lift the lid a little more or you want to let it be there. And can it be done at a later date, maybe 1 week or even 10 years after the initial process has taken place. And as I told you, temporal or nasal shifting can also be done. So thank you. This is a very innovative technique, and we are under publication also. And I hope this would be published in a very good journal. Thank you. Yes, madam.
So the sling is lying. So
yes.
How long will it lie, and how?
So normally the next post-operative day, we just pull the sling after we have adjusted the height and cut it. So the sling retracts back.
And we don't need to suture it?
No, nothing.
It will not slip away?
No, never.
Really?
I have done 160 cases.
Because when
I have all the videos.
Okay. So
Yes. It's like a Wattke sleeve, what you put in retina buckle. So you don't need to tie that after you have put the
जैसे
Watt's
जब हम
sleeve.
normally भी करते हैं frontal जो severe ptosis में when we
Yes.
do the
Yes.
frontalis suspension, that this
Yes.
is what it is you have showed.
Yes.
But उसमें भी सर सूचर लगाते हैं because there is always a risk of slipping it.
No, no, वहाँ तो
प्रोलीन
वो
सूचर लगाना
वो
पड़ता
तुमको
है.
टाई करना है.
हाँ.
टाई नहीं करेंगे तो कैसे होगा?
हाँ.
यहाँ पे आप स्लीव में डाल देंगे.
आपने ऐसे पास करके और वापस निकाल दिया
हाँ.
और उसको टाई भी नहीं
नहीं,
किया.
तो वाट्स के स्लीव बहुत टाइट होती है, वो उसको पकड़ा रहेगा.
So जो स्लिंग के साथ आती है वही स्लीव की
Exactly,
बात कर रहे हैं ना.
exactly.
अच्छा ठीक है.
हाँ हाँ.
जो बैंड बकल में यूज होती है that is different from what we get with the
In
Oro.
Oro sling there is a वाट्स के स्लीव there in the
होती है सर,
उसी
उसी को
उनके
यूज
साथ.
उसी से टाई करते हैं.
हाँ, तो उसी को अपोजिट डायरेक्शन में पास करना है. Normally what you do you pass in the same direction.
And then tie and then we bury it.
Yes. तो यहाँ पे you pass in the opposite direction and then you just leave it. It will never slip.
करके देखना
हाँ,
पड़ेगा.
sure.
तो यकीन नहीं
Yes,
हुआ. Difficult to believe.
Yes, yes. It's slightly different. हाँ, उसमें तो हम लोग को हटाना पड़ता है. इसमें हम लोग अगर पुल कर देंगे तो वो हो जाएगा.
Since we are
Yes.
running
We will have more time in our UPSOS session.
Yes.
we will move to the next.
Abdul.
Sir.
जैसे आपका इनोवेशन है,
हाँ.
इनोवेशन है,
हाँ.
तो आई थिंक यूपीएसएस जो इनोवेशंस कर रही है,
Yeah.
we should highlight it at the national platform.
So we are
And I
going
think
to
hats
have
off to both of you, sir.
We are going
we
to
are
have
very
innovation
poor
session
in-
on day 6, day 4. That's an innovation session which has been given to us. But अभी क्या है कि हम लोग इसको और highlight कर सकते हैं. Dr. Sakshi.
Should be highlighted.
Yeah, we have the last speaker for the session, Dr. Sakshi Kumar. She is a young ophthalmologist from Gorakhpur, and she will be speaking on Descemet detachment, a stumbling block for beginners in cataract surgery.
Good afternoon, everyone. Today I'm going to present a case highlighting the difficulty that we face in the cataract surgery. A 75-year-old male came to us with the complaints of defective vision in his left eye for past 2 months. It was insidious in onset and progressive in nature. There was history of cataract surgery 2 months back. He has been using eye drops NaCl 5% since then, and then he was referred to us when no improvement was seen. There was no history of trauma, pain or redness, and there was no systemic illness. On examination, right eye vision was 624 and other parameters were within normal limit, whereas left eye vision was finger counting close to face, and cornea showed epithelial edema with Descemet membrane folds with diffuse stromal edema, and there was a superior large DMD which was extending temporally. This was the picture which was taken when the patient came to us. I have tried to represent it through a handmade diagram. We performed an AIOS2025, and as you can see, there was a complete DMD which was superior in location and was extending temporally. On taking a treatment history, patient was initially kept on conservative management. He was started on topical corticosteroids, hyperosmotics, that is NaCl 5% drop 6 times and 6% ointment at bedtime. He was also kept on cycloplegics. Since he was not showing any improvement for past 2 months, he was advised to undergo desmetopexy with C3F8 gas. This is the video in which we performed desmetopexy. A side port was made, and then after forming the chamber, we had performed an inferior peripheral iridectomy and C3F8 gas was injected. After 2 hours of procedure, intraocular pressure was checked and it was found to be within normal limits. This was the picture preoperatively when the vision was finger counting close to face, whereas this was the image which was taken on post-op day 1, where vision significantly improved to 2/60. Discussing on DMD, as we all know, DMD is a diffuse corneal edema with slit lamp evidence of DM separation from posterior stroma at the site of corneal edema, as we can see in the diagram. Going to the epidemiology part, it is most common among the cataract surgeries. It has a high percentage in SICS, which is about 1.5% as compared to phaco, which is 0.5%. Gonioscopy incidence is 11 to 42%, whereas unreported small subclinical detachments we are not able to report because they resolve spontaneously within days after surgery. Clinical presentation is normally decreased vision, watering and photophobia, and signs are non-clearing corneal edema with slit lamp evidence of DM separation. Risk factors for DM are patient-related factors, intraoperative factors, and post-operative factors. Factors which lead to DMD during small incision cataract surgery. This is the main part which I want to focus. Patient-related factors, which can be shallow anterior chamber or pseudo-exfoliation, dense cataract or deep socket. The steps in which commonly DMD occur, which had happened to me in many cases, is during AC entry with keratome, during OVD insertion, or during nucleus delivery. And how can I prevent that? By proper preoperative workup, by proper handling of instruments near tunnel area and side port, and by slowly delivering the nucleus with enough viscoelastics. Classifying DMD, it can be either loose or taut. Loose part can be divided into unscrolled and scrolled, and unscrolled can be planar or non-planar. Another classification is the Duas classification. Management options. It depends on the following factors: size of DMD, whether visual axis is involved or not, scrolled, unscrolled, taut or loose. If it is a planar, unscrolled and loose DMD, we prefer not to do anything and we leave alone, just keeping the patient on conservative management, and anti-glaucoma medications can be added if required. In all other types of DMD, either we can do a manual repositioning, which is done via cyclodialysis spatula, Descemet membrane suturing, or we can do a desmetopexy, which we did in my case, where we can use gases like 100% air, which lasts for 3 to 4 days, hence it is least effective. 14% perfluoropropane C3F8, which lasts for up to 6 weeks, and 20% SF6, which lasts up to 2 weeks. Combination of anterior chamber gas injection plus surgical repair. These are some literature reviews, some studies which showed the effectiveness of desmetopexy. Another study which was published in the Journal of Cataract and Refractive Surgery. Thus, one more study is there which shows slit lamp based management algorithm, which again based on the classification helps us to decide whether we have to use air or we have to use SF6 or C3F8. In all cases, if the last resort when desmetopexy is failing is either to perform a penetrating keratoplasty or a Descemet stripping endothelial keratoplasty. Thus concluding, I can say that DMD is a vision-threatening complication of cataract surgery. Most are unrecognized and get spontaneously attached. Risk factors of DMD should be recognized and careful instrument handling should be done. For beginners during cataract surgery, anterior chamber injection of gas is the treatment of choice, and repeat desmetopexy should be performed before keratoplasty. Thank you.
Very nice. Thank you very much. We received the session 25 minutes late and we are giving up almost 20 minutes late, so 5 minutes we have taken over. Before we finish, Dr. N.K. Singh sir, please extend a memento to our convener, Dr. Navendu.
I would request all the speakers to please come up for a
and a photograph will take another 1 minute.
Chairperson and moderators of other session, please come on the dais. कैमरे में देखेंगे।